All right. Good afternoon, everyone. My name is Aura, and I'll be your host for today's webinar. We begin by acknowledging the Wurundjeri Woi Wurrung as the traditional custodians of the land on which our office stands, and pay our respects to their elders, past and present. We extend that respect to any Aboriginal and Torres Strait Islander people tuning in today. On behalf of the Mental Health Foundation Australia, I would like to welcome and acknowledge our guest speaker and member of our Scientific Advisory Committee, Associate Professor Scott Clark. Scott will be presenting today's webinar on personalised treatment with clozapine, considering ethnicity, information, and interaction. Thank you also to Dr. MGR Educational and Research Institute for their partnership and ongoing support of our webinar program. I would now like to introduce our presenter. Associate Professor Scott Clark is the head of Adelaide University Discipline of Psychiatry, managing teaching and research programs. He is also a community-based psychiatrist supporting people with treatment-resistant schizophrenia. He led the development of South Australian monitoring systems for the safe use of antipsychotic clozapine. His research focuses on biomarkers, prediction modelling, and the personalisation of mental health care. Please join me in welcoming Scott for his presentation. Thanks, Scott.
Thanks, Aura, and thanks to the Mental Health Foundation for the great work that they do and for having me today. I mean, this is a topic I'm really passionate about. I was just saying before, that is probably the best time, the most interesting time to be working in psychiatry because of the range of treatments that are coming and the knowledge that we're developing about psychosis. We've still got a long way to go, but there's some hope on the horizon, I think. So what I'm going to do today is I'll just load up my slide deck. I'm going to talk a little bit about personalisation of treatment response, but I'm going to focus mostly on safe treatment with clozapine and how we can use stratify that using our understanding of biology. Now I'll just try and share presenter view. Sorry, this is running really slowly. Should be up any second. Yeah, as I said, it's a really good time to be involved in psychiatry in general, I think, and really looking forward to what comes in the next 10 years to see how we can shape and improve care. I'm just trying to reshare. Okay. I should be able to get the right one. Sorry, all this taking time.
That's all right. If it struggles, maybe you can email me the presentation and I'll try to operate it.
Yeah, it's
up to you.
It's fairly big. It should work now.
Okay.
Like I've got the right field up, but here we go. Now, all right. Can everyone see that?
Yes.
Right. So thanks for your patience. So clozapine, as we know, is a unique atypical antipsychotic. It works in about 30% of cases where nothing else works. And really people have a transformative change in their life where clozapine works. And particularly after sometimes 10 years or more of cycling through existing drugs and not getting full response. It's different to the traditional atypical antipsychotics. It only loosely binds to and blocks dopamine receptors and has a range of other receptor binding that might be part of its efficacy, and it's also responsible for the range of side effects that we have to deal with. There's a lot of positives to clozapine. So just got something in the chat there. Oh, yeah. So apart from the fact that it's the best for response, it's the most effective for positive symptoms. It's one of the 2 drugs known to reduce rates of suicide with lithium, lowers the rates of overall mortality. It's largely through reducing suicide. It's anti-aggressive. Over extended periods, allows people to transition back into recovery and normal everyday living. Decreases hospital bed days. Low EPSEs because it doesn't have strong dopamine binding. And it's really cost effective, even though it has some extensive monitoring. So the history of clozapine is a checkered one. And I guess it was first discovered and used in trials in the 1960s, but in the mid-70s, there was a cluster of cases of granulocytosis, which 8 people died in Finland. And it wasn't until then, the 1980s, when Meltzer, John Kane and other people ran some trials and found it was more effective than chlorpromazine. However, because of the background of the granulocytosis, regular white cell count monitoring was implemented, and it's really the same protocol that we have today. Nothing's really challenged that yet. I'll tell you a little bit about some information that might challenge that coming up. But it's really to monitor for the incidence of granulocytosis. So just take a little segue and talk about what is treatment-resistant schizophrenia, and this is the current model from the TRIP group. And I guess we think broadly about the severity of psychosis, the impairment in function, and across domains, excluding pseudo-resistance, so making sure there's a reasonable length of treatment, 2 drugs times 6 weeks each, at a reasonable dose, with reasonable adherence. And it's a good point there to note that you can only really be sure of adherence if someone has had a trial of a long-acting injectable. 2 different types of antipsychotics, 2 different groups, and I've ruled out other reasons for psychosis. So we do come across patients, and I have, the last few years, a patient that was on clozapine for 10 years, plus a little bit of aripiprazole. The family and himself wanted to titrate off and try without it, and we did it over a year, and then he was fine on aripiprazole until he stopped taking aripiprazole. And then we went to long-acting injectable. But there are cases out there that potentially haven't been screened properly. So what's different about treatment-resistant schizophrenia? We can see here that there are a range of, so this is a paper by Spark that reviews the differences. And so at the level of the brain, there is increased glutamate as opposed to normal glutamate in non-treatment-resistant schizophrenia. In the striatum, most importantly, there is normal presynaptic dopamine function as opposed to increased presynaptic dopamine function in non-treatment resistant schizophrenia. And that's important because if you're going to treat someone with a drug that blocks dopamine, then it's not going to work in treatment resistance. So that makes biological sense. So there's different connectivity within the brain. We'll talk a bit about that later. And I guess we still have the ultra-resistant cases that don't respond to clozapine. And so there must be some other mechanisms working there. So we're looking at many schizophrenias. So here's an example of a paper by Varennes et al. That shows how presynaptic dopamine levels predict treatment response. And we can see here across multiple regions of the brain, if we look just at the striatum, that responders, non-responders have similar levels of presynaptic dopamine to controls, but those that respond to antidopaminergic agents actually have higher presynaptic dopamine. So if you're going to use an antidopaminergic agent, it's only going to work completely in this group. This is another interesting paper, and we do a lot of work in calculating polygenic risk. And this is another step forward in terms of stratifying patients. And here's a study that looked at developing a polygenic risk score just for dopaminergic genes that are in the striatum. And they found that they could improve the correlation and better predict those that predict the presynaptic dopamine, but also predict some functional responses as well. And that represents a step forward. Polygenic risk can really only calculate 1 or 2% of risk currently, but we're moving forward. And in lithium response prediction with polygenic risk, we can now predict about 13% of the variance, and that's using multiple different polygenic risk scores and compiling them together. And slowly we're chipping away at the variance and improving our ability to predict response, but combining those also with clinical symptoms of propensity to lithium response. So we're chipping away at this heterogeneity. Have we got that red mark on the screen? I'm sorry, I can't move that at the moment. I'm not sure what that is. The other thing is that psychosis is a disorder of connectivity. So if, I guess through development, the neurodevelopmental hypothesis suggests that we get a lot of synaptic proliferation in the early years, and through the teens, there's selective pruning. Across that period and into the 20s, we get myelination, which improves the efficiency of transmission. And we also get proliferation of inhibitory interneurons, which better regulates and controls behaviour. But in schizophrenia, all those processes are impaired. You get more pruning, you get less interneurons, and you get less myelination. And what you get is a brain that's not well connected. What we can see here is a really interesting study of relapse in patients that were maintained on a depot, the BAM group here, patients that relapsed when stopping oral, and then controls. And what we can see is striatal connectivity is much worse in these patients that relapsed on depot. So these patients are getting regular treatment, but even with regular treatment, they weren't actually able to maintain wellness. And so it might be moving forward that models of presynaptic dopamine, but also models of connectivity and other models as well, we can start to carve up and try and stratify which treatments we're going to give to which people. So it's really, there are many schizophrenias. There are dopaminergic abnormalities, glutamatergic abnormalities, and this is where clozapine might come in, normalizing NMDA receptor activity. Muscarinic abnormalities and AEST, the new anticholinergic muscarinic antipsychotic, is a good example here. So that's just passed a phase 3 second, so it's had a phase 2, phase 3, had an efficacy of about, an effect size of about 0.6%, had, it's a combination of a muscarinic M1 and M2 agonist with a peripheral antagonist to block the peripheral side effects, which were, I guess, inhibiting its use in Alzheimer's and other areas where it had been shown to improve cognitive function and reduce psychosis. And it's really the side effects, probably the most prominent one has been constipation. Most of them have been transient, and very low EPSEs because it's cholinergic. So it represents, it's about to go into longer trials, phase 3 trials. So that were 5 weeks. There's a couple of year-long trials coming up. And then there's an adjunct trial, so adding it onto existing antipsychotics. So that's an exciting space. But again, it shows that there's a different type of schizophrenia. It'd be very interesting to find which subgroup responds to that, because it suggests that it won't be everyone. And potentially it might be some of these non-dopaminergic cases as well. And there are other, there are 5-HT, cannabidiol response now. So we're slowly picking away. If anyone is interested, I can recommend having a look at the AMP Schizophrenia website. So this is a large consortium worth over $100 million US, collecting patients with early psychosis, with ultra high risk, clinical high risk for psychosis, and running an incredible array of biomarker studies, imaging, genetics, EEG, wearables, apps, and collecting that data. And that sort of data will help us to move forward and actually pick apart some of these mechanisms. So that's, we're talking there about how do we personalise treatment in terms of response, but the majority of my presentation today will really be about making clozapine more safe. And we've spent many years here setting up the monitoring systems in Adelaide. And we probably have I'd say it's world class, and it allows us to do research, and particularly we're focused on myocarditis at the moment. But there are a range of significant side effects that can be life-threatening that mean that clozapine is third line. The primary one was the granulocytosis back in the 70s when it first popped up. Here's an example of some local data. It's a little bit old now, but in a sample of 1,000 patients across Metro in Adelaide, nearly half of them presented with psychiatric illness, but over half of them presented with physical illness in the course of 15 months. So these patients are physically unwell, as well as their sort of psychiatric problems. And many of them went on to medical admissions. You can see here these blips, these lines are individual patients, and some of them had many medical admissions over that time. And of course, psych admissions, but also surgical admissions. So this is an unhealthy cohort, unfortunately. If we look at the nature of those admissions, A lot of them were for cardiac issues, and we know that the cardiac health of people with chronic schizophrenia is poor because of their smoking, their lifestyle, but also we're talking about clozapine patients here. We know there are cardiac complications. Trauma, some of that would have been self-harm, but also maybe by misadventure. Constipation, very high side effect. We know that clozapine slows the transit of through the bowel in everyone that takes it, and we need to be monitoring and to make sure that people that don't get severe constipation, because I know that locally in Adelaide, back in the day when we weren't monitoring, there have been deaths on campus at major hospitals because these things weren't monitored. Infections are very important things. So clozapine patients are predisposed to pneumonia and other infections, but also, as I'll show in a minute, infection causes raised levels because it causes inflammation that inhibits clozapine metabolism. And you can see that some of these patients then went on to get medical admissions, particularly for cardiac and infection issues and surgical issues. You can see because of lifestyle and other, these patients are at higher risk for things like cancer, and the infection in the surgical context is usually cellulitis. And so clozapine-related mortality. While we know there's the data from the Tihonen et al. Finn study there showing that clozapine actually is associated with reduced mortality, and largely because of, so that's higher cardiovascular disease, but reduced risk of suicide. If you look at the reporting data though, so this is a De Leon et al. Paper from last year that shows that in this large international pharmacovigilance database, the clozapine was the most reported, the mortality to clozapine was the most reported fatal event in the UK, and there's some numbers breaking that down there. But it's actually also very high in Oceania too. It was actually the most reports. And while there's a lot of potential bias in reporting databases, it shows that out of all the drugs, people are focused on clozapine and it's associated with events, but it is associated with significant amounts of mortality as opposed to the number of people on it. Having said that, everyone that needs clozapine should be able to have a trial of clozapine because it's so life transforming. So we're balancing these things all the time. So we know the monitoring, the Australian protocols, 18 weeks of white cell counts to look for granulocytosis weekly, and then moving over to monthly after that. We need a new prescription every 7 days or monthly. The CBE needs to occur with a certain timing, so it's difficult coordinating all of this. It can't be dispensed unless it's signed off, and the data goes into the monitoring database. And you can't brand substitute, so you've got to stay registered to the same database so that no cases of granulocytosis are missed and someone restarts on another brand with the risk of another episode of granulocytosis, which of course can lead to febrile neutropenia. And I guess those of you that regularly work with clozapine, we know that there are ranges for monitoring white cell counts, and if the white cell counts are dropping, then you increase monitoring, or if they drop far enough, you actually have to stop. It's a real opportunity cost when stopping, and I've had patients that have suicided because they couldn't manage the return of the psychosis when you had to stop, because once you're in the red, unless you can explain that there was a reason for the white cell count to go down, like a comorbid infection or another drug that caused it, then the patient's not allowed to take clozapine again, and it can be a terrible thing. Also with clozapine, there's a rapid loss of tolerance. So patients can quite rapidly, clozapine needs to be titrated slowly because there's severe sedation. There can be sort of early emerging myocarditis, anagranulocytosis, but really sedation and respiratory repression earlier on. If you stop for a week or so, and greater than 48 hours is the limit that's enforced, then people can become quite sedated, particularly if they're on high doses. And I know in our service, most years there's sort of 1 or 2 patients that end up severely sedated because they've either inadvertently stopped and started at home, or even it happens in care in facilities where people that are not familiar with clozapine start back at full dose, and people become very sedated and can require ICU. So we do a range of other monitoring because of all these other side effects, and particularly cardiovascular. And we look very closely at cardiac indices for emerging myocarditis. Anyone who's interested, we've got very detailed documentation on our website, which is listed there, about how we go about all this. So the interesting thing about clozapine, well, one of the interesting things about clozapine, I've spent a lot of my life wondering about some of these things, is that it's highly variable in terms of its plasma levels. It is 95% protein bound, and those proteins can change in their expression as well with inflammation. But a lot of things interact with clozapine, particularly at CYP1A2, and it has a range of other effects there. So, for instance, smoking induces 1A2, and so puts levels down. But if you stop smoking, then all of a sudden the levels jump up, and particularly if you're in hospital and you're on the wrong antibiotic that also inhibits 1A2, ciprofloxacin or the like, then all of a sudden you can have a massive increase in dose over a week, and toxicity can emerge. So in terms of therapeutic range, there's been a number of studies done, and between 350 and 400 micrograms per litre is the optimal level for response. So with all drugs, I guess you titrate to effect. If you haven't reached 350 and you haven't got full benefit, then the idea is that you'll try to go to 350. Some people require higher doses, but from about 500, risk of seizures and risk of other serious side effects occur. And I guess you've just got to balance that and titrate and over time. When people get infections, their levels will go up. And so you might find people that come in sedated, myoclonic jerks, constipated, and then you really should be thinking about taking a level, doing a CRP to see if there's significant inflammation, and thinking about adjusting dose. It takes generally 2 or 3 days to get a clozapine level back. You can look at the clozapine norclozapine range to try and assess whether people are taking it regularly, or whether there's other inhibitors, whether metabolism is being changed, if people are rapid or slow metabolizers. So here's the crux of the presentation today in terms of talking about personalisation. So Jose De Leon's been championing this guideline that is sort of published over in a number of different versions over the last few years, based on many years of I guess interest in pharmacology and clinical practice, and there are suggestions, all the data is not fully complete and needs more exploration, but the suggestion is that the Asian people and Native American people have lower CYP1A2 activity, and so they need lower doses to get a therapeutic response. At higher doses, they will get side effects. Sub-Saharan African ancestry may need higher olanzapine, CYP1A2, and therefore also higher clozapine doses. Suggests there are sex smoking-based groups. So females need lower doses, but non-smokers also need lower doses because 1A2 is not induced. Females, because estrogens themselves inhibit 1A2, and so lower levels are safer. And then there's the absence of the presence of poor metabolizer status. So there are a number of functional or non-functional alleles, and depending on your genotype, you might be a rapid or poor metabolizer. And there's also environmental contributors. So obesity, inflammation, chronic disease. Inflammation itself will inhibit 1A2, and then early levels during titration will go up, putting people at more risk of side effects. And environmental exposures, so smoking, of course, is one of those, but also just drug interactions. So if we look at the alleles that have been shown to be associated with poor metabolism, in European samples, we have 1A2, 6, and 7. And these are different forms of 1A2, different genes associated, and when it's expressed, the enzyme's just not as efficient. East Asians in that geographic range have, there are a number of alleles that have little to no function, and if you have these genotypes, then potentially you're a slow metabolizer and at higher risk of side effects. And sub-Saharan Africans, it's a bit mixed. Now, the African population, we're just completing a review looking at a polygenic risk scores and also pharmacogenetic studies across across Africa, and we found some mixed results. But potentially the suggestion there is that it depends on the subgroup, but there is probably more CYP activity in many of the groups. It means that they might need a larger dose to manage. So you can see here that one size doesn't fit all, and personalisation is about trying to better match a person's predisposition, what they're exposed to, and the drug. So personal environmental poor metabolizers, inflammation, as I said, and that could be chronic inflammatory disease, infection, or obesity. You'll see elevated C-reactive protein and even small amounts. But if you see, a C-reactive protein in the 20s or 30s, what you're going to find is probably the clozapine level is up. If you stop smoking, the clozapine level can double over a week. And I guess clozapine itself, and this is sort of one of the newer findings, is that it induces inflammation. So the reason we have to titrate so slowly is that initial dosing over the first few weeks to months, the clozapine is causing inflammation. And so clozapine-related fevers are common. Myocarditis is more common in Australia than anywhere else, potentially because we titrate a little bit faster. We're still trying to, it's hard to get complete information on that, but we're setting up studies in Adelaide to look at that more closely. It causes a body-wide inflammation, so which is focused in different organs depending on the individual, but probably most commonly being myocarditis. But the fever suggests that probably underlying this is a CRP rise and an early sort of clozapine rise that potentially underlies many patients. But it's time limited. It peaks and then drops off again over months. So the time around myocarditis, the worst timing is the first 2 or 3 months. Medication interaction, so oral contraceptives, valproate, and a number of antipsychotics all increase levels. So if there's polypharmacy, you're more likely to be on a high level initially. Here's some data that there's a review that I did with Dan Siskind a few years ago, looking at the existing case reports of clozapine-related toxicity related to infection. And we pulled together 8 new cases. We've found that you can see in the graph there that there was a wide range of responses and some very high levels associated with infections. And of course, the higher the dose, the more the enzymes inhibited with the infection, you're more likely to end up with very high levels. And these are quite concerning levels that one wonders, and I'll show you some data in a minute, whether people that the mortality in the community where levels are high, whether there's been an underlying infection. So these high levels were associated with smoking cessation, along with the infection and certain antibiotics that will inhibit 1A2 or 3A4. And so it means that, and we've been doing this for, we've been monitoring for the first 4 weeks CRP and troponin for myocarditis, but if sort of routine white cell counts, taking white cell count and a CRP, checking if someone's got a good going infection, and a clozapine level at the time of the infection to check if you need to actually reduce the dose. If a patient looks sedated and they get constipated, there's myoclonic jerks or the like, then potentially you need to think about slowly reducing the dose. Here's this is a dump of all the clozapine levels in South Australia at the major pathology provider back from 2000 to 2010. So you can see there's a vast range of levels. 1,000 really is the consensus high level, given the risk. Some people push up to there. From 500, you get more seizures. Down at 350, you get efficacy. We've systematically, I haven't got a new dump, but we've systematically found people running high and intervene to try and reduce the tail of that curve. But potentially, and some of these are actually deaths, but clozapine does concentrate in the blood after death, so it's hard to get a good venous idea of what the level was at the time of death, but potentially associated with seizures or sedation due to that increased level. It's interesting that a recent study shows that that in a reasonable sized hospital population that episodes of inflammation were common, and that if you looked at the clozapine levels, then a significant number of people required dose reductions to maintain therapeutic and not super therapeutic levels. So we can think of a model where clozapine itself causes inflammatory response, which can cause neutropenia, pneumonitis, myocarditis, cardiomyopathy, happens after many episodes of myocarditis. The inflammatory response itself, plus all these other environmental facts, can actually inhibit CY1A2 activity, and that puts the clozapine level up again, so you get a bit of a vicious cycle there. Any infection will do that, and obesity and metabolic syndrome will do that as well. So if we just take a think about what is the most important thing to monitor for clozapine patients, and of course we know that granulocytosis was the main problem that brought clozapine to the risk of clozapine to our attention. But you can see, and this is some data by Dan Cohen, who showed that did a review and showed that the mortality rate, particularly for myocarditis, constipation, ketoacidosis, is much higher than granulocytosis. You can see here the wide range of variation of rates of myocarditis in Australia. We've just looked at, so this is again working with Dan Siskin and crew. We've just looked at all of the white cell count values for all of the patients under Viatris in Australia and New Zealand for the last 20 years, and found that there's a suggestion that there's a lot of isolated minor neutropenia that occurs. If you separate that out from serious neutropenia, the rates of serious neutropenia are really quite small. And so some people will have white cell counts that might bounce around, or they might have a single adverse event. And if you look at after 2 years, the rates of new white cell count, new episodes of neutropenia are really quite low. And so the suggestion is that we could actually lower the thresholds and potentially think about reducing the amount of monitoring at least after 2 years. Also, if you look at and so you can see this in the red curve, the difference between serious events and isolated minor neutropenias, which are really no risk to the patient. If you look at the blue lines here, it shows patients that have previously been on clozapine and restarted after a break in therapy, and it appears the risk is even lower in terms of the risk of particularly any serious events is very negligible. So once you've had 2 years of monitoring, even if you stop and start again, there might not be any point. And I mean, we're discussing this with regulators and other things at the moment. And if we were to change in terms of monitoring processes, we'd need to go through the TGA, and we'd need to replicate this data. But 2.6 million data points is pretty impressive in terms of the strength of these associations. So is neutropenia the most serious thing that we need to manage? And I'd probably suggest no. It'd be pneumonia and myocarditis, and we're particularly focusing on myocarditis now. So the problem with myocarditis is it's hard to diagnose. So most of it's viral. We know that the rates are higher in clozapine treatment, but you can't truly be sure that it's not a viral myocarditis unless you actually do a biopsy. And so we have, I guess, rules. Kathy Ronaldson's developed a protocol which we've implemented since 2011. But there's an acute inflammation, some edema and swelling. If clozapine is stopped, then the myocarditis will heal. If there's ongoing inflammation, and potentially what happens in clozapine that leads to cardiomyopathy is that you get multiple episodes of myocarditis, potentially with the patient starting and stopping clozapine all the time, because it tends to happen over a short period. So myocarditis is a serious issue. As I said, it can be caused by many things, and so actually being sure it's the clozapine is important. And I guess if it starts within the first few weeks to months of clozapine treatment, and there is a change in heart function in terms of reduction in echo values, you have to really be concerned. But you have to have a sense of concern that you have to potentially try and rule out some other causes. So could it be in Australia that we have more myocarditis because we titrate faster? So locally in South Australia, I know we've got about 8%. I've done sampling across the Central Adelaide Hope Local Health Network. Internationally, rates are very low, and particularly in areas that have outpatient clozapine programs, which might be as much to a half sort of. So we tend to titrate to 200 milligrams by day 14, and that's about a third sort of faster than some European and Japanese protocols where they do have less rates of adverse events. So the potential is that we're titrating too fast. We also rely a lot on troponin values, and especially locally, and I'll show you some problems that can lead to. Now, I'm sorry, my screen has gone blank. Can everyone still see my screen?
I can, yes. It's still on the rapid titration and
slides. Just give me a second. They've come back. A couple of things. I got a few messages and it kind of messed things up there for a second. There we go. All right. So are we titrating too fast, or are we looking too closely? Other questions. And as I said, yeah, there are some places where much lower titration rates they've had a look, particularly at inflammatory response, and it's been lower. And particularly this DRESS syndrome, which kind of matches potentially what's happening with clozapine, where we know that we get hypereosinophilia in some cases. Doesn't happen to everybody, and that's associated with myocarditis, but there's an inflammatory response to the clozapine itself. So there's a number of other mechanisms that have been proposed, and we need to keep an open mind because, you know, myocarditis is a complex response. Here's Ronaldson's rules, I guess. Here we've got a standard case of myocarditis, how it evolves over days to weeks, and usually there's there might be a tachycardia. A lot of patients get tachycardia and onset of some sort of non-specific viral illness and fever over the first couple of weeks, and then heart rate rises again over over a week, 1 to 5 days, and then you start getting raises in troponin, so indicating that there's been cellular damage. And at the same time, there's an elevation of CRP, indicating that there's inflammation. Those two things together form part of the Ronaldson screening program. So high CRP over 100 plus 2 times upper normal limit of troponin. And then you get significantly, and then you get changes in left ventricular function on echo and changes in ECG. If you stop clozapine, it generally resolves within a few days, but it's important to actually pick it up within these early periods so that there's not any severe damage that's done. We had a look at how people were trying to pick up myocarditis in Adelaide, and we used Ronaldson's criteria, and we found 24 potential cases based on troponin rise and CRP rise. 9 were formally diagnosed, but only 7 met the criteria. So there's some kind of variation creeping in here. We found 8 that were based on the established definition, which is new signs of cardiac dysfunction, troponin and CRP. And so this is where we get sort of our 8% of new commencements. They were younger, more often prescribed additional antipsychotics like clozapine, which has been associated with more rates of myocarditis, higher risk. And there were 14 undiagnosed potential cases that didn't have timely testing. It's either that there was a one-off test and they didn't look at the evolution over time, or there was no testing at all. You know, there were monitoring tests that weren't picked that weren't actually properly followed up. And 6 cases that failed to consider CAM in the context of an early negative troponin. So the first troponin, not repeating it to, even though there's clinical symptoms. And so it may be that this inflammation is going on in a lot of patients that we're not really picking up, and most people survive it. And that's that early tachycardia. And there's I guess there's a gradient of severity that happens depending on your underlying genetics and what other medications you're on. And 2 cases of inappropriate early cessation, which is terrible. You don't want patients to miss out on the benefits of clozapine. And so we kind of need to do better. The other thing is it's hard that it's hard to use troponins effectively because there's a lot of variation in the tests themselves. And so here's a case. I was a 22-year-old, had a year of significant symptoms, significant impact on his life. He was a refugee who was come over and isolated from family, and there was some aggressive behaviours and treated ineffectively. He started clozapine, titrated to 300 over 3 months, Had some residual ideas, but was much calmer, much better, and was looking at getting work, transferred to my care. He had a persistent tachycardia though, but his troponin I and COP were normal. Added a bit of atenolol to control the rate, cardiology review, followed all the guidelines. We added abravadine, which is a rate control agent, rather than atenolol. But the patient still had symptoms, so he wanted to try. So we slowly titrated his dose up. There was a minimal improvement. The tachycardia was controlled. But then I changed testing and to troponin T just for convenience at one time, and he was troponin positive, low moderate level troponin positive. So we repeated echo, we rate controlled, worked with the cardiologist, slowly tapered his medication, and it stayed positive over a long time. But then in that process, one time we had to do we had to use a lab that used the troponin I, and it was negative. So I've got a test that in some places is positive, in other places is negative. So do we stop the clozapine and actually lose the opportunity for this patient to get better? Instead, we worked, because they were sort of lowish, moderate troponins, we worked with cardiology to try and manage this and keep him going and increase the rate of testing. Clinically, he was fine. The tachycardia was controlled. Amisulpride made things worse, trying to spare clozapine and reduce the dose. Eventually got him down to 175, still with some residual symptoms, and the troponin increased for 9 months. This man is now, he's actually transitioned out of my care because he moved area, but he was able to return to full-time work and university, and has successfully studying at university. And this was a guy who was severely unwell, and without clozapine, he wouldn't have been able to do that. So it's very important to try and maintain people on clozapine where we can and get around this extra sensitivity. And you can see here the course of troponin and CRP. So the T's were positive because it's sensitive, and the I's were negative. See, there wasn't much CRP, so there's and the levels of troponin worsened as I increased dose, so it was dose responsive, and as the clozapine level went up here. His heart rate was relatively well controlled, and the control got better over time, and eventually the troponin dropped off, but we persisted. And looking at troponin, the T and I do different jobs in terms of muscle contraction, there's also a C component. I won't go into too much detail here, but they form part of this complex that allows muscles to contract. I guess the important thing to note is that T is more sensitive in terms of a test for myocarditis. The other thing is there's a lot of confounding factors. So clots, renal failure, heart failure, muscle damage that can elevate troponin. You need to rule those things out. You need to be aware of them. Other antibodies. So it's not as cut and dry as just looking at the troponin level and interpreting it directly. And then what we did, we had a look around, because I got the feeling that these tests weren't all telling me the same thing. And we looked across all the local labs and found that everyone was running different machines and different tests. And so it was very hard to use a threshold of 2 times the upper limit to actually say, well, we need to stop the clozapine now. And so the risk was that you were stopping people inappropriately and giving them rebound psychosis, or taking away the opportunity for them to, to improve and flourish and recover. And so what we did is we changed the threshold to include all of these levels in a normal level where it was safe. And we discussed this with cardiologists and SA pathology, and that's now become our SA cardiac guidelines. So we've expanded the range of troponins that are acceptable and are safe, and we haven't had any specific adverse events. That's been running now since 2022 that we can pinpoint. The great thing is that we're now starting studies to look at this implementation in more detail, because we've implemented data capture in our electronic health records, and we can extract this data. So we're about to start on another range of that. So really, we want to be avoiding these adverse events. We want to personalise people's care to try and limit the risk of developing myocarditis or other inflammation. Not so sure if particularly associated with the granulocytosis yet, but potentially metabolic syndrome and other things. But so this is a titration guideline that Jose de Leon and a range of international experts published in the last couple of years. And what it shows is that what it suggests, and it's really not been fully trialled yet, is that we can adjust doses based on ethnicity, based on smoking status and gender, and then also based on the presence of environmental risk factors like obesity, like other medications. And that we should be looking at clozapine levels about week 1 to see early evolving peaks in clozapine that might be associated with tachycardia, fevers, and that could potentially be associated with inflammation. So I looked at these risk factors, and we did an audit of a number of 217 commencements, and we found 4 cases of confirmed myocarditis. And across these cases, we found that all of them had at least one risk factor for poor metabolism, whether it be environmental, through interactions or obesity, whether it was due to being of Asian descent, whether their smoking cessation was in place. And you can see on the far right the dose at week 2 as opposed to the personalised recommended dose. And you can see that in most cases, sort of the dose was at the other end of potentially where it could have been more slowly elevated, more slowly titrated, and potentially patients may not need the same dose. What we really need to do is to trial this approach in a proper clinical trial. But I think there's evidence accumulating that we need to be careful for people that have these risk factors and personalise them using ethnicity and these other risk factors. So, in summary, clozapine is a highly effective drug for treatment-resistant schizophrenia. Science is working towards the stratification of treatment resistance. We're getting small gains with understanding presynaptic dopamine synthesis and the range, the heterogeneity in schizophrenias. And we hope sort of over the next sort of 10 to 20 years, we can develop better ways to stratify people into, predict who's going to need clozapine up front. But we've also got, as we understand more about the mechanisms of psychosis, we're also getting a range of new drugs, and that will be really exciting. Basically, one day we may be able to use biomarkers, clinical features to actually reduce the time to getting someone on the medication that works for them. The other point here is that, clozapine causes inflammation and inhibits its own metabolism. So we need to be mindful that the inflammation is a significant problem for clozapine. Over COVID, we implemented some monitoring, closer monitoring for patients that were infected with COVID, and we get to analyse that data. But anecdotally, a lot of their clozapine levels were raised, and so we watch them more closely to try and reduce any risk. So clozapine levels are highly variable, both between and within individuals, and they're affected by ancestry, genetics, sex, smoking, inflammation, and drug interactions. And if we can stratify better patients by those factors, then we might be able to reduce the range of adverse events, and potentially slow titration will be safer in these patients. It's suggested that the maximum dose as part of de Leon's guideline is reduced in these patients because of these interacting factors. And so potentially that wouldn't extend lengths of stay as long as people actually respond to the lower doses. And that's one question that remains in my mind, is if we don't push to 350, we know that everyone doesn't need 350, but if we don't push to 350, are we not treating people properly? And I guess there's that trade-off with time in care if we have to go slower. But rapid titration might be associated with higher peaks of inflammation that are linked to adverse events. And monitoring protocols, including troponin, they're sensitive but not specific. And we need to use troponin with understanding the clinical picture and not have too many knee-jerk reactions, and reach out to cardiologists and have them involved in care. But personalising dosing based on risk factors might reduce the rates of those adverse events. And that leads me to my last slide, which is a study that we're in process of implementing called Capture, where we're adding an extra blood tube and looking at the proteomics of the inflammatory response as it emerges over the first 4 weeks. And so I hope to come back to you in a couple of years and be able to tell you exactly what's going wrong. And we can push safe care with clozapine forward. So thank you very much. Happy to take any questions.
Great. Thanks, Scott. That was certainly very insightful. So yeah, we've got a few minutes for Q&A. So if any of our audience wants to, ask Scott some questions, if you're curious about anything that's being presented. Otherwise, I have a sample question. So, Scott, you mentioned earlier about KarXT, which is, the new antipsychotic that's such an exciting new topic for schizophrenia treatment. So what are your thoughts on it?
Well, I think it speaks directly to the fact that there are many schizophrenias and probably many mechanisms, and having an agent that has very low EPSE side effects. It sounds like there are some gastrointestinal ones which you would think with a cholinergic agent, but they're better managed with this peripheral anticholinergic that's there. I mean, the safety data is only up to 5 weeks so far, and the efficacy data is only up to 5 weeks. So we need to wait on the year-long studies to see how that goes. But it's very, I think it's very exciting. It gives people another option. Potentially, we'll be able to treat a different cohort of people, or we might be able to add on as well. So that's another study that's running. But I think until we get the year-long study in terms of the safety, we won't know 100%. But it's promising so far. I think I guess people that manage schizophrenia, psychiatrists, are interested and excited to see what the next study leads to. There will also be the process of getting it registered, but the FDA and of course the TGA probably have pushed through some drugs recently fairly quickly. So depends on what happens in the next 12 months, I think 2 years.
Yeah, of course. Would you consider working with KarXT if it...
Oh, well, look, based on this, as I said, acutely it looks fine, and it looks effective. We don't know the patient cohort it works in yet, which is that stratification question. But there are some transient gastrointestinal side effects in some people, but it looks promising. It's hard to say until that year-long data's out.
Yeah, of course. No audience questions. I guess another question I have is, how do you envision the future of personalized clozapine treatment evolving, and what challenges need to be addressed to realize its full potential?
Well, as I said, I think we need to look at personalising care through gathering more data and potentially trialling those approaches. To some extent, people do that in normal clinical practice, because if patients are developing side effects, you won't follow the normal dose titration, you'll go slow. If you know that there are comorbidities, you'll take more care. But I don't think we understand the range of situations where we should be taking more care with that titration. And I'd like to see us get a better handle on managing these markers of myocarditis and inflammation, so that we are not pulling the trigger too early or stopping medications too early, but we're making sure people are safe. And potentially also we might be able to reduce rates of myocarditis, but cardiomyopathy is it's low numbers in terms of risk, but it still occurs. But if you can manage the myocarditis, we might be able to manage the cardiomyopathy as well. And who knows, if we can manage the inflammation, we might manage a whole heap of the side effects. We might see a granulocytosis disappear. We're not sure of all these mechanisms. Yeah. But I think by measuring changes more closely, I can remember one of my mentors saying, "Oh, clozapine, all the research has been done. There's no more research to be done." And I think far from it. It's it's an incredibly interesting molecule. We don't know why it works. We're starting to unpick how brain networks work, understand how clozapine could be affecting sort of any MDA receptors and functional integration. I think we're only just at the tip of the iceberg in terms of using it as a tool to understand the nature of schizophrenia. So I think that's exciting.
Great. All right, well, in that case, we might wrap it up here. Thank you, Scott, again for your insights. So on behalf of the Mental Health Foundation Australia, we sincerely thank you for taking the time to present today's webinar. And of course, we look forward to future opportunities of collaborating again. So,
thanks, Laura.
Yeah,
Always happy to help out.
Yeah, I'd also now like to invite Dr. Deepa Lakshmi, Senior Resident from the Department of Psychiatry from Sri Lalithambigai Medical College and Hospital to deliver the vote of thanks on behalf of Dr. MGR Education and Research Institute.
Thank you, ma'am. On behalf of Department of Psychiatry, myself, Dr. Deepa Lakshmi, Senior Resident, Sri Lalithambigai Medical College and Hospital, Chennai. Would like to thank our Honorable Chairman, Dr. A.C. Shanmugam Sir, our President, Engineer ACS Arun Kumar Sir, beloved Vice Chancellor Ma'am, Dr. S. Geeta Lakshmi. I am privileged to thank our speaker, Scott Clark, Associate Professor, Discipline Head, Psychiatry, University of Adelaide, for his enlightening talk on clozapine use in treatment-resistant schizophrenia. The discussion on various mechanisms causing the inflammation, especially the myocarditis, on the patients with treatment on schizophrenia, clozapine, was very much useful. And I also extend my sincere thanks to Mr. Vasan Srinivasan, CEO, Mental Health Foundation, Australia, Dr. S. Amuda Kumar, Consultant, Mehta's Multispeciality Hospitals, and also Orogo, ma'am, for inviting us. Many thanks to our respected Dean Sir, Dr. Mala Subramaniam, Dr. R. Kausalya, Dean International Relation and Collaboration Cell, respected Medical Superintendent Sir, Dr. Senthilnathan Sir, our Joint Registrar Admin, Dr. Manivannan Sir. I once again thank one and all for making this event a grand success. Thank you.
Thank you for that. And if any of you would like to rewatch the webinar, it will be available on our YouTube channel. Our website is mhfa.org.au. So if you head on there, all the information is available online. So thank you, everyone, once again, and we hope to see you again next time.
Have a great day, all.
You too. Bye.